Welcome, everyone. We will start in just a moment. Hello, everyone. Welcome to today's industry showcase. My name is Amanda McKinley. I am the manager of member engagement here at Digital Health Canada. A reminder that this showcase is being recorded and will be available for viewing from the Digital Health Canada website. Today's industry showcase is presented by the American Medical Association. CPT coding moves with modern medicine. Moderating today's presentation is Dean Parisi, Director of International at the American Medical Association. Q&A will take place at the end of today's presentation. Please type your questions in the Q&A box at any time. Please ensure that your questions are in the Q&A and not in the chat box. Thank you so much for being here today. I will now pass the presentation over to Dean.
Thank you, Amanda, and thank you everybody for joining today's webinar. A special thank you to Digital Health Canada for hosting today's industry showcase. In terms of today's webinar, we have introductions. We'll talk about healthcare system challenges. We'll talk specifically around the exploration of CPT, current procedural terminology, and how it keeps pace with modern medicine. We'll also give examples of how CPT has responded to the COVID-19 pandemic. Also cite examples around telehealth, telemedicine, as well as augmented intelligence. We'll also then provide a use case around how CPT is being used today in Alberta. And last but not least, we'll have a Q&A session at the end. In terms of today's speakers, again, my name is Dean Parisi. I am the Director of International within our Health Solutions Department at the American Medical Association. I'm delighted to be joined virtually from Chicago by my colleague, Leslie Prellwitz. Leslie is also a director within our Health Solution Group, focusing specifically on CPT content and CPT management. We're also delighted to be joined from Calgary by Dr. Jia Hu. Dr. Hu is a physician, a primary care physician in the province of Alberta. He's also an assistant professor at the University of Calgary. Good afternoon, Dr. Hu, and thank you for joining us today. How are things up in Calgary?
Oh, actually pretty nice, sunny. Anyways, it snowed like on Sunday. It'll snow again tomorrow, but I should get started. So thanks for the introductions, Dean. I have some other jobs, but I think that to not perseverate, because I don't like these long introductions. I'm a family doc who does work in both sort of clinical and long-term care settings, but I've also been quite involved in the COVID-19 response and sort of all aspects of it, from testing to tracing to vaccine rollout. And so, thank you all for attending today. And, I just wanted to start by actually, if you go to the next slide, talking a little bit about some of the challenges that, we face with some of our billing codes in Canada right now. And for those of you that sort of don't know how billing codes and physician payments work in Canada, in general, most physicians are paid through a sort of a fee-for-service model. Fee-for-service defined as for a certain service, let's say, doing an heart transplant or, swabbing somebody's throat for strep throat. There's certain diagnostic codes and billing codes attached with each of those activities. And, I think that we have a lot of different billing codes. The provinces have different billing codes, and we'll talk about why that can create a few problems right now. And so on the slide, you have on the far left sort of current state, how some of the general issues this creates, and then some of the unique challenges I think that's sort of created with COVID-19. So, I think one thing to recognize is that, many of our codes are very old. When I say very old, sometimes years and not decades old, and they don't necessarily reflect the realities of how work is being done currently and how care is being provided currently. I think that, an example of that is, I think that there's a lot of sort of old procedures that are sort of paid the same way as they were when they were done 30 years ago. There's a lot of new procedures that aren't even necessarily on the codes, and that's sort of why an outdated code can lead to sort of a combination of both, over delivery of unnecessary care as well as under delivery of necessary care. And that's sort of the general health system issue that creates. I think part of the reason why they're outdated is that the updates are sort of inconsistent and often ad hoc, also not necessarily evidence-based. And, when I say they're inconsistent and ad hoc, every province, as sort of has its own healthcare system in a way. Canada is really a country with, 13 health systems for each of the provinces and the territories. And so, the code for a particular procedure in Alberta, even if it's the exact same thing, can be very different than that same procedure being done in Ontario or Nova Scotia or, in Nunavut. And, that leads to a lot of interprovincial variation. When it comes to, and that's probably not that's not a good thing. When it comes to, how these are updated, I think that, different provinces have sort of different mechanisms for that. But, the updating is sort of ad hoc. There's a lot of, I'd say, politics involved in them. And I think that what we ideally want is sort of an evidence-based process. It's very evident to me that clearly somebody doing an open heart surgery or heart transplant should be sort of remunerated better than, somebody doing a COVID test. But the extent to which that should be the case, the magnitude, this is where a bit of evidence, the input of clinicians who do all sorts of procedures becomes quite important. And fundamentally, if you are, if physicians are being compensated differently for the exact same procedure based on the province you live in, that will lead to inconsistency in care, and that's not good. Linked to the inconsistency and lack of updating is my last sort of current state point, which it becomes difficult to incentivize certain innovations. For example, like even the treatment of new disease states, novel types of care. And, I think that when I say novel types of care, it doesn't necessarily mean, flashy new MRI machines, though those are always very important too, but even different models of care. And I'll explain a bit with the COVID thing. And, I think that what we do want is an innovative, dynamic health system that can reflect the changing realities of healthcare. And, healthcare changes so quickly, and we've certainly seen that happen during the pandemic more than ever. And we want to be timely, and we want to be introducing innovation that improves care. And we want to, do that as consistently as possible. Now, if I think about sort of the COVID experience, you think about what did the outdated codes do? When COVID came along, we needed to have codes for testing, for treatment, for vaccination, and especially for virtual care, actually, given how many clinic offices were closed for COVID and everything else. And, I think prior to COVID existing, there were some virtual billing codes, whether phone consults or sort of telehealth consults. But they were, in their infancy, and, the inability to have really robust virtual care at the outset, I think certainly drove or being to see, which is lack of critical routine preventative care. And so being able to have non-outdated codes is super, super important. When I talk about the inconsistency, I'll use the virtual care code as an example because it's pretty interesting. Again, different provinces were using different amounts for their virtual codes versus in-person visits. And, I think that can lead to some really bizarre incentives. For example, if you're being paid a lot more for an in-person visit than a virtual visit, even though the virtual visit is just as good, you might be incentivized to bring a patient in, even when you probably shouldn't, given that, you're in a first wave or a second wave or a third wave. And, I think that, of course, most clinicians try to do what's best for the patient, but, people are sort of driven by this, and that's just sort of like known to be the case. And then lastly, when I think about innovation, right, I think that with COVID, we've seen the critical importance of, again, we have needed the scale up of all sorts of testing for regular COVID and variant, but, innovation around providing a wraparound social care for patients, right? People who have trouble isolating because they don't necessarily have the income support, they don't have the time off work and those sorts of things. Providing that sort of social care, quite critical, not just for the patient, but for the entire sort of pandemic response. And, as a former medical officer of health, like controlling the pandemic is quite critical in what individual patients, the people did. And, without the correct codes for that type of counseling and support, that wasn't happening. And we had to, fix some of that up in real time. And so I think that with all that, I think it's pretty well known to the health system, some of these challenges that have existed within our billing systems for many years, if not decades. And there has been movement towards reforming, the way that billing codes work. And, just go to the next slide, actually. I think that one really cool thing that, I'll hand it back over to you to talk about is the CPT code set, but I did want to sort of frame the problem initially, and I'll come back on later. So thank you.
Yes, thank you, Dr. Hu, for that overview and insight into the coding system and some of the challenges that you've experienced firsthand as it relates to COVID-19 and social care. Before we move on the path towards CPT, or current procedural terminology, what I'd like to do for a moment is introduce the American Medical Association and our strategic focus. The American Medical Association has 4 strategic arcs. First, we represent the voice of the physician with a unified voice. We're a 175-year-old medical association headquartered in Chicago. 2, we lead the charge on confronting today's public health crises. Since the 1970s, where we've taken anti-tobacco policy positions, to more recently the opioid crisis and initiatives to curb the opioid consumption, to most recently the efforts around COVID-19 and the codification to support the vaccines as well as COVID-related care. And most recently, the investments that we've made in health equity with the development of our Center for Health Equity. Again, these are just examples of how we continue to confront public health crises. We also remove obstacles that interfere with that precious relationship between the physician and the patient. Later in today's presentation, my colleague Leslie will give examples specifically about modifications that we did to the evaluation and management codes, which are a set of codes, category 1 codes within the CPT code set that are intended to provide more time for the physician and his or her patient. Again, we recognize with the proliferation of technology and EMRs and EHRs, our physicians were telling us they're spending more time on the administrative side and less time on their care. So again, Leslie will give us a specific example of how not only we heard that feedback, but we made modifications, again, to remove those obstacles. And last but not least, we drive the future of innovation in healthcare. The AMA invested in an organization called Health 2047 in Silicon Valley, where we incubate and advance healthcare technologies. Again, not just for technology's sake, but with the understanding of how can we adopt and utilize CPT, again, to improve our healthcare ecosystem and that relationship with the patient. Next slide, please. Underpinning our strategic arcs are the 5 parts of our organization. We are at the core a membership organization. We also have a House of Delegates where we establish policy. We also have practice and business tools. Within our practice and business tools segment is where our health solutions organization sits. That's where current procedural terminology sits as well. We're also a research and education association. Many of you may know us for JAMA, the Journal of the American Medical Association. And last but not least, we are an advocacy organization with offices in Chicago and both Washington, D.C., again, advocating on physicians' rights. Next slide, please. Again, as a mission and vision-based organization, CPT is a nomenclature dating back to 1966. It is roughly 50 years old. It's a code set that underpins our healthcare delivery system in the United States in terms of procedures. It's also used by a number of different governments across the globe, currently used in 4 governments outside of the United States. And it's actually used in roughly 40 countries in a variety of different capacity with healthcare technology firms. Again, at the core, CPT is a code set that is evidence-based, physician-led, and governed by our CPT editorial panel process that drives interoperability, standardization, as well as transparency and research. We like to look at CPT in the context of improving the quality of care, again, by driving standardization and interoperability. The cost of care, by having a standardized code set that underpins the health delivery system, we can drive efficiencies and improve outcomes, again, due to the standard language. And of course, access to care. By having a standardized code set, we are able to improve outcomes by, again, having a common language from across Hawaii to Maine down to Florida, a standardized healthcare delivery system that improves access to care. Next slide, please. It's oftentimes people ask us in what care settings or what environments is CPT being used. We're delighted to say that CPT can be used across a variety of care settings, whether it's inpatient or outpatient services, to home service, including domicile, as well as nursing facilities or critical care. CPT has been constructed and developed in a way that is applicable and can be used across a variety of care settings. My colleague Leslie momentarily will talk about, again, the construction of CPT, how it's managed, how it's utilized, and give examples of how it's used in these different care settings, and also how CPT has been able to keep pace with modern medicine. Leslie, welcome to today's webinar.
Thanks, Dean, and good day to everyone. It's great to be with you today. So I'm going to take you through a little bit about how the CPT code set is constructed, how it's used, and a number of other issues, and particularly how we've responded to COVID-19 and some of the other items that Dean had discussed in terms of V&M. So when we talk about the code set, oftentimes people think a code set is simply a list of codes and a list of descriptions, and that's it. And with CPT, that's only the beginning, in that the main codes and their descriptors are supported by a whole structure of components that help to promote consistent, accurate interpretation and application of the codes. So some of the key components you see here obviously include our descriptors, as CPT is the language of medicine, is the language of the work of the physician, that we have a variety of descriptors depending on where the codes are used. So our official long descriptors are officially define the codes and the descriptions of what's included in that work. The short and medium descriptors are more designed for use in electronic health record systems where you don't have that much visual space, but you still need to understand the code that's being used. Clinician descriptors are used for practice at the point of care. And consumer descriptors are created specifically for a non-clinical audience for use in patient-facing portals and systems so that patients can also understand the care that's been provided to them. Other components include modifiers. As we all know, when you take care of patients, it's very difficult to find one patient that is exactly like another patient. And sometimes you need to account for variations from care, procedures that are more complex than maybe you intended, or multiple procedures to be done. And that's what modifiers allow you to do. So the work is still reflected, but we recognize when you have to do something that's a little different from standard. Guidelines and instructions, as with any language, we all need rules to understand how the language is constructed, that everyone has a common understanding. And that's the goal of all of the guidelines and instructions for use of the codes, to make sure that you've got uniform code usage. And that's really key to establishing a common understanding across the healthcare sphere, so that every time you see a particular code, a 5-digit code with a descriptor, everyone knows what it means. It's applied the same way, and it really helps in terms of consistency and increased quality of care. Now let's go to the next slide and we'll talk a little bit about some of the different structures. So it's not just all of those components, but the actual code descriptors themselves are designed to drive efficiency in identifying the services that are provided. Certainly very few of us have too much time on our hands, and accuracy in selecting specifics that reflect the work performed relative to the type of procedure. So there's a few common examples that we have here. Our standalone codes, when your procedure is very straightforward, so an incision and drainage of a hematoma, seroma, fluid collection, there's not a lot of variation with a procedure like that. So that's one code, one descriptor, simple case. One case that's maybe not so simple is when you get to something like coronary artery bypass, where the basic procedure is known, but the length and complexity can vary a little bit depending on how many vessels are being bypassed. Is it one? Is it two? Is it three? And so we do have codes and similar to what you see structured here, where the base code, the 33510, would be your base code, and everything before that semicolon says, here's the main procedure we're doing. And then beyond that, you get small variations. Is it 2 graphs? Is it 3 graphs? The complexity goes up with that. And so the codes are designed to give you the idea that these are grouped together. You don't have to read that base description too many times, but you can select the code that most closely identifies with the work that you're doing. Add-on codes, skin tags is probably a great example. You're removing a certain set of skin tags. Usually it's for a particular number that are being removed. And then there's an additional code put with a plus sign. And again, it's designed to be an add-on to the initial one, so we don't repeat all of that verbiage. But you can see if you have to do each additional 10 lesions in this case. So there's a way you can report both that 11210, and then if you have multiple tags, you report the additional code so it reflects that you've got work that's been extended simply due to the number of items that are being done. Usually is how an add-on code is constructed. Now, the next slide, we're going to talk a little bit about some of the different structures in terms of the different code categories. And this really helps to design and give you a flavor for the different categories of procedures that are covered with CPT. It's designed to capture both industry standard as well as emerging technologies and performance improvement codes. So our category 1 codes are really our most extensive section of codes. These are your procedures and services. They're consistent with contemporary practice. These are your gold standard, evidence-based, clinically recognized, generally accepted, performed across a wide population, our standard set of codes. They'll have a 5-digit identifier, and there's also additional work that goes with those codes. So it's not just a description, but there's a lot of work that goes behind the scenes that quantifies specifically what is the work that's included in that code. And that's very important for all of these because that helps with that common language. So whoever sees that code, if you wonder what type of work is included in this particular service, there's a description that tells you exactly that. Now, category 2 codes are more for our performance measurement, and they speak to address the quality of care. So oftentimes these are conditions where perhaps there's a nationally established performance measure or a desire to improve quality of care, say for diabetes, asthma, any of your chronic conditions, and that they also have an evidence base that's contributing to the quality patient care. So it's not just what service was done, but how did you do it? Did the patient get all of the education that they needed to do? Did they get the medication management that they needed? And so there are codes that actually track those types of conditions. The structure of the code is a little bit different. We do that by design, so you can almost tell just by the structure of a code, if it's 5 digits, 4 digits, and a letter, that gives you a sense as to what category those codes fall into. Now, category 3 is a very important category because that really helps to identify our emerging technology and procedures. These are codes particularly for new technologies that may not yet have the widespread utilization that you would expect with a category 1 code, but perhaps they're on the path to that. So the purpose of these codes really helps to permit data collection and to give some rigor and full strength in terms of defining those codes. They are designed to be temporary as they're emerging, and so they have a shelf life of about 5 years, but they can be reinstated if things are going well. And oftentimes, those are areas where we see codes that eventually may become those industry standard codes. So this is sort of a training proving ground, if you will. Proprietary lab analyses are specifically for the rapid innovation that's going on in terms of access to care with laboratory testing. It's a very fast growing area. And these are codes created specifically for labs and manufacturers that want to identify a particular laboratory test. And again, there's a very unique structure to those codes. So you can just tell at a glance which code category you're looking in. And the CPT is designed to capture all of these and maintain all of these categories going forward. Now, I want to talk a little bit about category 3 in a little more detail. So on the next slide, we talk a bit about category 3 codes in particular. Now, these are our innovative procedures. This is new and emerging technology, procedures, services, procedure service paradigms. Again, they're specifically created for data collection with those brand new technologies. They are one of our most visible areas of change. Many codes in CPT are updated on an annual basis. This one's actually updated twice a year. So we capture that as it rolls through. We bring that out to the market 2 times a year. And this has been one of the most fastest growing areas of CPT. For the last 10 or 11 years, there's been at least 10% volume growth in this category. And if you looked at this category in 2011 and you looked at it today, only about a fourth of the codes that were in 2011 are still in there today. It's moving just that rapidly. That whole category has more than doubled since 2011, and it continues to evolve with many of our codes. And as I indicated, oftentimes this is their temporary codes, but they're designed to sort of be, many of these will eventually, as they gain usage, as we get that data collection, as we get that evidence, many of them sort of step up to be our category 1 standard codes. So that's just one way that innovation comes in. And on the next couple of slides, I want to go over some of the results of how CPT has moved to keep pace with modern medicine, particularly in the areas of digital medicine, virtual medicine, remote medicine, and physiologic monitoring have been some of our key areas. So these three really, it's a blend of category 1 codes. So some of these have come in and gone straight to that evidence-based status. And they're really addressing technological changes in innovation and keeping pace with changes in practice. So as an example, your first one on the left, it's looking at interpersonal consultations between physicians. That's nothing new. But what was new for this year was really creating a set of codes that addressed how that work is performed when you're using the internet, when it's a little more than just a telephone. We had codes before, but the question is the work different when you're reporting the sending of results and there's not necessarily a verbal telephone communication? How do you handle that? Now there are codes that specifically address that in addition to the phones, but we bring up how you address it through portals when you're sending that type of information and assessments. Remote physiologic monitoring. This one was huge. Not only was it a large advance into digital medicine, but also with the pandemic, as many people were shut in, unable to get to their physician offices in a live fashion. As you can imagine, chronic conditions still happen. Patients with heart failure still need to be monitored. Patients with diabetes and asthma still need to be monitored. How do you do that when the patient is constantly at home, can't get in to see you? So between 2019 and 2020, the editorial panel, which is a little bit of the fuel behind all of these codes, actually created 4 new codes to allow physicians to monitor remotely their patients. So even if their patient is far in a distant rural area, they're still able to communicate with them. They're still able to get perhaps data from monitoring of various types of devices and machines, do that analysis and help to provide that patient care. And again, that's a different type of work than you might typically do if you see the patient in office. And so now there are codes that actually reflect the new work that has to be done. Pulmonary artery pressure sensor remote monitoring was a special one that was set up. Heart failure patients are standard for remote physiologic monitoring codes. In this case, there's additional time and complexity required with the pressure sensor remote monitoring, and we created special codes just for that particular type of work. And so all of these have come on in the last 2 years. These first ones were put in 2019. Who knew we would use them as much as we did in 2020? But they truly help to increase access to care for patients that truly could not get into the office, and physicians were still able to keep up with them. Now, the next slide goes into a few more codes that we've done with digital medicine, and these are more focused on how you interact with patients in particular. So just as we had an interpersonal consult code for the internet between physicians on the last page, now there's one for patients when they're communicating with you via a portal. E-visits, how do those happen? So there's lists of codes to manage those types of activities, as well as something like self-measured blood pressure monitoring. So the patient's taking their measurements and they're bringing them in or they're transmitting them. And what are the items and maybe some of the standards that should be followed with that type of data collection where the patients may be a little bit more involved. The work for the physician is a little different in that instance. And so now again, there are codes that can reflect that. And the last two, one is a category 1 and one is a category 3. And both of these have to do with AI technologies. And actually, the remote retinal imaging is our very first AI service in the CPT code set. And it's important when you think about the work done by the physician in a particular exam. It's a very interesting question now with new technology. We're thinking, well, what happens to physician work when perhaps that machine is doing a little bit more in terms of analyzing and working with algorithms than it did before? How does that impact? And how does the physician sort of be recognized in that new realm? So now there are CPT codes that are moving on with that, and we're having a continuing number of additional items as technology moves, digital medicine moves. There's no shortage of ideas, fantastic ideas for new ways to provide care. And the great thing about CPT is it's designed to manage all of those. Now, on the next page, I'll go a little bit in terms of some of the examples of what some of these code descriptions look like. I won't read it in a lot of detail, but this was a group for the remote physiologic monitoring parameters. And in this case, these were actually prepared as a group because, as you can see, they're going to reflect the different types of work performed. So there may be a certain level of work that's performed when you're initially educating the patient on the use of the equipment. There may be one in terms of actually supplying a device and having it programmed and ready to go so the patient's able to use it. How to actually manage and maybe discuss items with that patient. And maybe it's over a month's time for a chronic condition. It may not be something that you report each and every time, but it's more convenient to capture that information in time over a month's time and report as a group. And then there's analyzing and processing of the data that comes back. So each of those are different components, and we've put them into different codes as a group, but that way the physician or their physician staff is able to select the activity that most closely reflects what they're doing in that particular area. So I've talked a little bit about some of these codes, and one thing to remember with CPT is that these are definitely not created in a vacuum, in a back room at the AMA, that there is an entire structure that works with creation of these codes, and that's really put together on the next slide. And it's important that people understand that behind all of the CPT code set, everything that you see, is the CPT editorial panel. So that's a thorough, transparent, physician-led, evidence-based, clinically valid, deliberation-driven process with the sole focus of creating, revising, and updating these codes, descriptions, and the guidelines, everything that's created in that set for appropriate CPT reporting. There's a core group of 17 members of the editorial panel. They are appointed by the AMA Board of Trustees, representing a number of different societies, medical specialty societies, pretty much all MDs. Their panel is focused on the CPT, so while they may have a particular specialty, once they're appointed to the panel, they are focused on CPT themselves. They do not advocate for their particular specialty or their particular society because the focus is on the code set and what's needed for appropriate reporting. Now, obviously, 17 people can't do it alone, so they are supported by a clinical expertise from all across medicine. Our advisories committees make up the majority of our medical specialties, are represented there in the House of Delegates of the American Medical Association, as well as support from our non-physician groups. So many of our allied health areas are represented. So we get input also beyond the physician base. So your psychologists, physical therapists, optometrists, they have input into the process in many of those codes as well, because some of them relate to things that they actually perform. There are a number of standard groups, work groups that work on particular areas. I'll talk about a few of those in the next couple of slides when we get there. We're not there yet. But also we have representation from the payer community. Both government and commercial payers have insight and transparency into this process, as well as the ability for input from industry manufacturers, particularly with labs with some of those very specialized codes, that there's opportunities for them to present as well. Now, this group meets 3 times a year in public face-to-face meetings. There's literally thousands of volunteers and hundreds of participants who come together to create these codes and maintain and move them forward. Now, you might ideally think that a structure this large must, by definition, be slow to react, and not able to move nimbly to respond to anything, because you would think a ship this large cannot possibly move fast. That could not be farther from the truth. And the best way I can explain that is to discuss our response when it came to the COVID-19 pandemic. So let's talk a little bit about that. And on the next slide, we're going to go through a little bit of the content that we've actually done to support the COVID-19 response. So that editorial panel, when this all started to start happening last year, just about this time last year, they were committed to providing COVID-19 related CPT codes for the medical profession while maintaining that process integrity. So the rigor, the review, the input from all of the societies, none of that was compromised as we were going through this. And while that team normally meets 3 times a year, I will say from firsthand experience that our very first meeting was for a first emergency panel meeting was held in 2020 for the very first COVID-19 CPT testing code. That was the first one to come out. That happened on a Friday afternoon. And some of our work groups, our standing work groups, we have one that's devoted to testing for different types of pathogens, our pathology coding caucus. They'd done a lot of initial homework. We got an application in front of that editorial panel. They reviewed it. The meeting was held at 5 p.m. Rather than codes waiting to be held until the first of the year, the very first testing code was released about an hour after that meeting began. And the following Monday, we were all working from home. So since then, but the work did not stop at all. Over the year, the panel held about 11 emergency CPT panel meetings, and every time, pretty much once a month like clockwork, new codes were being released. First with the testing, point of care testing, tests that were sent out to labs, then moving on to the panel tests, and then moving on to tests such as when it became flu season. The tests came out to look for either COVID or influenza, so those would come out as well. So every month there were new testing codes that came out. And then when it became appropriate, we started to work on the vaccines that have also come out in the last few months. So every time something has come up, this team has actually worked pretty much on a monthly basis to get new codes out. So we didn't wait. We've come up with so far 24 new COVID-19 CPT codes in 2020. So it handles testing, vaccines. In this case, we had some unique challenges with vaccines because we not only had to have a code for the vaccine itself, but there was a particular requirement from some of our government agencies that we have more detailed tracking of the administration of those vaccines. And it wasn't only based on a particular vaccine, but also what is the dosage? Are you giving the first dose, second dose, single dose? And the CPT structure simply stepped up. And in this case, we created a new structure for COVID vaccine administration codes that handles that flexibility. We don't know how many there will eventually be, but we're well poised. As long as we don't have more than 100 vaccines on the market, I think we're set. But the whole idea was to get those codes so they can support monitoring and planning and what's needed for the population to be able to manage this pandemic. So that's COVID. At the same time, we were all moving and working in telehealth. Again, places were shut down. People couldn't get around. How do you provide care to your remote populations or newly remote populations when everyone is isolated and quarantined? Now, there's a set of codes, about 70 codes within the CPT that are already designated to be used in a telehealth and a synchronous telehealth environment, audio, visual communication, and other criteria. During the public health emergency, during the pandemic, we were able to work with government coordination to temporarily expand that list by a factor of almost 4 to a whole new set of CPT codes that could be conducted in a telehealth environment. And the great thing is that the codes already existed. We simply had to give the authorization for them to be used in a new area. And so some of those are existing for the time of the public health emergency while that's still going on. But the great thing is that CPT was already poised to do that. We just needed to work with our government agencies to make that available to our new population. So a lot of work has been going on and more still continues with COVID and telehealth, but CPT is certainly keeping up the pace with all of that. Now, the AMA provides more than just CPT codes. And on the next slide, I'll just walk briefly through And I believe this is going to be left behind for many people, but there's a number of different COVID-19 resources that are available to physicians and physician practices. Because when you think about it, it's more than just the codes, but how do you work with how actually implementing telemedicine in practice? In our areas, many times telemedicine until the pandemic was really limited to patients in remote rural areas. Well, overnight, a number of physicians had to get used to and familiar with, how do I apply telemedicine practices? I'm in an urban area. I'm not used to doing this. We help you work with that. Digital health implementation playbook to help use all the new digital technology and how to actually implement it well in your practice, as well as the JAMA Network COVID-19 Resource Center on the diagnosis and treatment of COVID-19. So there's a wide variety of resources that the AMA provides. So it's more than just codes, but to actually help you implement them efficiently in your practice. We do have an online tool for our vaccine and vaccine administration codes. As new vaccines come online, they continue to come online. We actually have that handy reference tool so that you can pair up the appropriate vaccine with its vaccine administration code because it is new. So we give those additional resources as well. Now, innovation doesn't just sit with new codes. As Dean had indicated, we also make sure that CPT has innovations for existing codes when it's needed. And the next slide really goes over that, particularly with our evaluation and management codes. Now, these are your standard bread and butter codes that are used by nearly all physician specialties. So if you are seeing a patient in your office, you're doing inpatient rounds on the inpatient units, you're seeing them in the emergency department, nursing home facilities, your standard visit codes, this is what evaluation and management is around. These codes have been around for quite some time. They're used by nearly everyone. And over time, what we found, among other things, was that there was a need to reduce and impact the physician burden that a lot of the technology had brought in with your EMRs and EHRs. Adina had indicated a lot of times what you get is practices where the doctor is spending so much time in front of a computer, they're not able to spend as much time with their patients. And that just didn't seem quite right. So there were a number of additional factors, but what CPT has done is they have embarked on a process to take a look at all of the codes, all of the guidelines, and really see how does that fit with modern practice? How do we reduce the burden for our physicians so that they can spend more time with their patients and be able to really use those cognitive skills in reporting the services that they're providing without having a lot of unnecessary box checking, if you will. So the very first set of codes that was updated in 2021, effective in 2021, were our office or other outpatient codes. There are 10 little codes, but they are enormously impactful and that they're used by nearly everyone and every physician. Those were done in 2021. There's a special multi-specialty work group that's been set up, and the remainder of everything else that you see in that circle, all of those other codes, are slated for revision in 2023. So the work does not end. And it's really a great example of how CPT is able to look at not only new and innovative technologies, but also taking a look at your standards and your bellwethers and making sure that they keep pace with modern medicine as well. So with that, I'll actually turn it back to Dr. Hu, and I'd like to hear a little bit more about your assessment and what you see in terms of CPT and addressing challenges to improve patient care with some of the challenge that you laid out at the beginning. So I'd love to hear your perspective.
Yeah, no, thank you for that sort of overall description. And, I think, I mean, fundamentally, I think it really does address all of these challenges, right? The fact that you could have CPT allows for the I mean, here are the main things. I'll be a bit systematic, right? I said one of the problems are outdated codes, right? And clearly CPT meets regularly and more than just regularly when, you need to do that. And that's what we had to do for COVID because stuff literally changes every week. Obviously the way that the codes are updated is through, I really like this, a panel of experts that's, as evidence-based as possible. And when I think about how codes are updated, like normally in government, you have experts on, but it's often a little more political in a way, right? And every province will be different. And I think that, having that evidence-based sort of expert involvement is really critical. And, just the broad use of it, just the consistency is so important too, because one of the big things I've had to deal with actually is just I work a lot in the other provinces too. And it's just sort of like, how do I try to calibrate, or if I've identified these certain best practices for COVID, but there's different codes and different remunerations for different types of behavior. How do I try to level what people do when they're being paid differently to do different things for the exact same work? And I think that having CPT would definitely resolve that issue. And, I think that obviously, quite innovative in terms of some of the, like the AI stuff, super cool. But again, I'll say it again, care models are as important in my world. I think, well, it depends on what you're doing, right? And so I think, if you think about what CPT does is, it's evidence-based, it's timely, it's validated, created by experts. And I think all those things, fundamentally do, when I think about what the macro goals of the health system are, right? Like one is we want people to have quality care. We want people to have access to that quality care. I mean, I can put access as part of quality. We want that to be done in a cost as possible, and that's where sort of the evidence comes in. And lastly, you want the same care in Alberta as you do in the Yukon as much as possible. And I think CPT enables all of that. Yes, for COVID-19, which I've sort of been deeply enmeshed in, but for the thousands of other conditions that doctors across hospitals and clinics and all the stuff in between treat on a day-to-day basis. So I mean, there is no single perfect solution, but I think that this is certainly a much better solution than sort of what we have going in most of our provinces. And so I think it's pretty wonderful. And I should shut up because I feel like we should leave some more time for Q&A.
Thank you, Dr. Hu, for, again, that summary of some of the challenges and perhaps how CPT, the code set, could help. I think you've got one last slide here in terms of the current use case, but Amanda, just given our limited time, perhaps if we can move forward. Yeah, one thing, actually, if we can go back, I think it's worth saying, again, a special thank you to Dr. Hu for outlining some of the challenges that you have, not only in the province, but perhaps pan-Canadian. And then Leslie for her insight into the overview, the construction of CPT, the panel process, again, how it keeps pace with modern medicine, but at the same time is pliable enough to support changes, including, but not limited to, the virtual care that we heard, COVID-19 and the number, roughly 24 codes that we've developed over the past year, let alone not mentioning the number of emergency meetings that we've had to pull together. And I think roughly, Leslie, if I'm not mistaken, there was about 10 emergency sessions, panel sessions. Is that correct?
Yes, that's correct. And they were pulled together on pretty short notice, but a process that normally takes a few months, 4 to 6 months to go through the full process, was happening in a matter of weeks every time. So yes, 10's pretty accurate.
Thank you for that. And last but not least, we didn't touch on this, but we have, as for a takeaway, feel free. We've got some information as relates to AMA CPT resources that are available. So not only does the AMA license the CPT code set, we actually provide a number of supporting material and products. For example, we have print and digital material to help educate not only the governments that may be interested in learning CPT, but those extended ecosystems of outpatient, inpatient environments. Again, we have a number of print and digital resources. We also have developed a couple introductory courses to help, again, administrators to physicians understand CPT in a little bit more greater detail than Leslie laid out. And then last but not least, we have an implementation guide, which is a roughly comprehensive 12-chapter overview that doesn't talk so much about the what, but about the how. So if a province or a government, whether it be in Canada or outside of North America, was interested, again, this is intended to be a comprehensive document that walks through how you would implement CPT within your respective environment. I see we are coming, Amanda, nearly to the end of today's session. At this point, if we can open it up to Q&A, I think we've got roughly 7 or 8 minutes. While we're doing that, I think we do have one question that has come in already. And let's take a look at it. Question is, in your role, perhaps Dr. Hu, this is addressed to you, in your role as chair of 19 to 0, how do you think CPT coding could help Canada better manage the COVID-19 experience?
Oh, I feel like I've actually talked about that a lot. I also didn't explain what 9.0 was, but that's okay. I mean, like, again, I said, we want timely evidence-based codes, right? And we've seen that the need for that more than ever for COVID-19, right? And there are real consequences to not having that, right? Like, it's been quite I mean, realistically, we've built some amazing supports for patients, like the wraparound social care, that is largely being done for free by people because codes don't exist for it. And, I think that's very nice of people and physicians to do that. But I don't think that's a long-term model for sustainability and success. I did want to mention, and I was going to talk briefly a bit about sort of NSQIP and sort of some of the surgical sort of outcome pieces as well. But, I've talked so much about COVID-19. I mean, I do work in a lot of other spaces like, mental health and sort of anything you would see in a primary care clinic. And, I think in Alberta, we've already begun to sort of pilot CPT in sort of some of our sort of surgical settings. And, I think we have, begun to see the sort of, economic and care benefits of that. And so while we have indexed a lot on COVID-19, it can, CPT is for everything, right? And, I think about what we need to do effectively after COVID-19 ends. There's a big backlog of surgeries that need to be addressed. That's a huge priority of governments all across our country. There's a huge mental health sort of pandemic that's broiling. And, if the codes don't reflect the care needed, and there's going to be new, realistically, I mean, in a way, we've always had mental health issues and we've always had surgical backlogs, but never to this extent, right? And I think, CPT can address those issues as well, because it's been, effectively been used to address some of the COVID issues, in the United States. So I will stop and let others ask questions.
Thank you, Jia, Dr. Hu, for that response. And a couple questions are indeed coming in. It looks like this next question, Leslie, perhaps may be directed to you. How does CPT support the work of the health information professional?
Oh, excellent question. So in terms of supporting the work of the HIM professional, I think CPT, probably the one item I would focus on is consistency. When you're looking at being able to accurately record the health of a patient or the conditions and going on with the patient, one thing to remember is when you're taking a look at that patient's care, there's no, the nice thing about CPT, at least as it's used here in the US, is it's a national standard that's used across the country. So no matter where that patient goes, what care they have to receive, what discussions need to happen between clinicians as to what's happened here when they need to get referred to a specialist. Do they understand everything that happened when the patient was at home, even when they're 500 kilometers away in another province? Or does there have to be a translation of care? And while there can be a translation among code sets, as with anyone who's worked with code sets or any kind of translation, there's always a risk that you miss something. Did you accurately capture and reflect the work that was done for that patient? So the benefit of CPT is it's one language that everyone understands. And so you don't have to worry about that translation. Also when you're looking at, say, taking a look at health outcomes across broad populations, it again helps to have that common language so everyone understands it, how it's performed. If you look at that code, you can have confidence that it's been used with the same rules and guidelines as which you're interpreting the results. So those are probably some of the benefits I would see with the HIM professionals. You have one language, everyone understands it, and it does account for those different dialects with modifiers and looking at care in slightly different settings, and it accommodates all of those. So that's probably where I would definitely support the work of the HIM professional. You don't have to learn multiple languages, you learn one.
Thank you, Leslie. I think we've got another question for you. Comes from an anonymous attendee. What do you see as the relationship between CPT and ICD-10-CA?
All right. Well, CPT is a procedural-based coding system. So it's talking about what is the work or the service that the physician or other kind of clinical professional is providing to the patient that day. So that's one set of codes. Your ICD-10s, and it's ICD-10-CA in Canada, it's ICD-10-CM here in the States, is saying, what's wrong today? Why are you here? I used to always talk when I was in the academic space that we are managing hospitals, not hotels. You have to be here for some reason. And so the nice thing about ICD-10-CA, it's very similar to the CM modules, and they're actually used together here in the States. Again, one describes the service that's provided. The other says why you're providing the service. Now, the benefit is that the CPT has additional flexibility in that it is not inextricably tied to ICD-10. Many people think that the two, that if there's a certain procedure, that it must have certain diagnoses that are connected to it by default. And it's not constructed that way. Now, there can be things from just a matter of, does it make medical sense that you wouldn't expect to see certain diagnoses paired with procedures? But it makes for a very good pairing because one says why you're here, one says what's being done today. So they're very complementary to each other. And we've used those in various variants of ICD in the States for many years, well, decades actually. And the nice thing is that when we're looking in other geographies, it's also flexible with other diagnostic systems as well for that same reason.
Thank you, Leslie. And actually a follow-on question to that, Dr. Hu, we may require your insight as well for this one. The question is then, so is CPT more compatible than with CCI for intervention codes? And I believe CCI is a Canadian classification of interventions, if I'm not mistaken. So perhaps Dr. Hu and Leslie, if you can tackle that question, perhaps jointly.
Yeah, I mean, I think that, I mean, we tend to use ICD, like when we bill, like in all the provinces, we use an ICD code and like a billing code, right? And so I think it's quite compatible with the ICD 9, 10, 10-CA. You know, I think, yeah, that's probably what I would say. Leslie, I don't know if you have any other like insights into this sort of CCI thing.
Yeah, I think when it comes to CCIs, it's I think what you said is pretty accurate with that. I mean, I'm trying to think if there are particular applications in Canada around CCIs that I would bring forward with that, but none that's particular come to mind. But Dean, I would like to take that offline if we can get some of that back to some of our participants. That would be a great one, I know, to check out, especially when you're looking at coding nomenclatures and systems. Again, trying to figure out how many do you need to capture the work that you're doing. It's a very important question. So I would like to do a little bit more work on that one.
Excellent, thank you. And it looks
Sure.
like we've got time for perhaps one more, maybe two more. The next one is fairly brief. Will this today's presentation be made available in terms of the actual webinar or presentation? And I think, Amanda, the answer to that is correct. Is that?
Yes, that's correct. So the webinar today, our industry showcase, is being recorded. It will be available for members and non-members to view from the Digital Health Canada website. You can go to Digital Health Canada website, click on our webinars tab, and then click on industry showcase, past industry showcases, and it'll take you straight to where the recording is.
Thank you, Amanda. And it looks like a last question here then is, AMA, you mentioned that CPT is being used in other countries. Can you give an example of how it's being used? I think, Leslie, Dr. Hu, I could probably tackle that one. So indeed, CPT has been adopted by a number of countries around the globe. For example, Cyprus recently adopted, back 2 years ago, CPT as the underpinning procedural terminology for the NHS, the Republic of Cyprus National Health Service, which previous to that, did not have a standardized coding language for procedures, and had come to us in a way to drive, again, transparency, interoperability, and improve overall analytics. They adopted, again, CPT within their NHS system. Another example that recently comes to mind is the United Arab Emirates. The UAE has been using in various forms CPT dating back to 2011, particularly for a claims adjudication system, both within the Emirate of Abu Dhabi and Dubai. Dubai's product called is eClaim Link, again, where payers and providers come together in a standard government portal and submit claims that, again, is underpinned by current procedural terminology. Looks like Amanda has come back online. I believe that's our cue to close down today's webinar. And before we do so, again, I would like to thank Dr. Hu for his insights and perspectives from Calgary, Leslie for her dissection and overview of the CPT code set, and again, Amanda and Digital Health Canada for hosting today's industry showcase.
Well, thank you, Dean. Thank you, Dr. Hu, and thank you, Leslie, for a wonderful presentation. Thank you, everybody, for participating in today's industry showcase. We will be sending out a short survey after today's presentation. Please look for that in your email. We look forward to receiving your feedback. And thank you very much, everyone. Please stay safe, wash your hands, and have a wonderful week. Thank you, everyone.